enormously, continuously.
The benign prostatic hypertrophy, or BPH, refers to histologic changes within the prostate gland. Hyperplasia means increase the number of cells, which is different from hypertrophy, which refers to an increase in size of the cells. The risk factors include family history and advancing age. However, evidence suggesting comorbidity, environmental, dietary, or lifestyle-related risk factors is generally weak. The BPH begins with abnormal microscopic hyperplasia, leading to macroscopic growth. This involves the formation of soft, yellow-pink nodules by epithelial and fibromuscular stromal cells. This causes outflow obstruction and obstructive voiding symptoms, like decreased force of stream, intermittent stream, and hesitancy. Actually, this process is driven by 5-alpha reductase activity in the prostate, which increases with age, leading to increased dihydrotestosterone production. Dihydrotestosterone then makes prostate cells live longer and multiply faster. This is actually a normal process of aging, and around 50% of men develop BPH by the age of 60. BPH is not associated with any increased risk for developing prostate cancer. Rather, as the prostate gland enlarges, small hyperplastic nodules can form within it. Hyperplastic nodules will typically form in the periurethral region of the prostate. In response to increased resistance, the detrusor muscle generates higher pressure to overcome it. This leads to a variety of cellular and morphologic changes in the bladder, causing common storage symptoms such as frequency, urgency, and nocturia. Eventually, this can result in bladder decompensation, where the bladder is unable to generate sufficient pressure for emptying. Conditions associated with BPH include overreactive bladder and sexual dysfunction. We will discuss those diseases later. Then, taking a patient's history, focus on identifying the presence of lower urinary tract symptoms, such as voiding symptoms, previously called obstructive symptoms, like hesitancy, intermittency, weak stream, abdominal straining to void, post-void dribbling, incomplete emptying, and double voiding. Storage symptoms, previously called irritative symptoms, like daytime frequency, nocturia, urgency, urge incontinence, enuresis, and dysuria. Also, identify other factors contributing to LUDS, such as medication, for example diuretics or cold medication, comorbidities like diabetes, multiple sclerosis, and Parkinson, previous intervention or therapies, and family history. During the patient's history taking, you should conduct tests such as the International Prostate Symptom Score or an equivalent test like the American Urological Association Symptom Score, along with quality of life assessment. The IPSS, or the International Prostate Symptom Score, is used to measure the severity of lower urinary tract symptoms. As a validated, reproducing scoring system to assess disease severity and response to therapy. The IPSS is made up of 7 questions related to voiding symptoms. A score of 0 to 7 indicates mild symptoms, 8 to 19 indicates moderate symptoms, and 20 to 35 indicates severe symptoms. It is not a reliable diagnostic tool for lower urinary tract symptoms suggestive of BPH, but can be used to quantitatively measure LUTS after a diagnostic is made. The questions look like that. Over the past months, how often have you had the feeling of not completely emptying your bladder after you finish urinating? How often have you had to urinate again less than 2 hours after you finish urinating? How often have you found that you stopped and started again several times then you urinated? How often have you found it hard to hold your urine? How often have you had a weak urine stream? How often have you had to push and strain to begin urination? Have you had to get up to urinate during the night? The links to the test will be in the description below. In a physical examination, you need to examine the external genitalia, evaluate the abdomen, pelvis, and perineum, perform a digital rectal examination to estimate prostate size and detect any nodularity suggestive of prostate cancer, and make sure to note anal sphincter tone and sensation. In digital rectal examination, prostate will be symmetrical and large, smooth, firm, non-tender with rubbery or elastic texture. Also conduct a focused neurological examination on the anus and lower extremity motor and sensory function. A more extensive neurological exam is recommended for patients with potential lower urinary tract dysfunction. The laboratory tests include urinalysis to rule out hematuria or sign of infection. Levels of prostate-specific antigen will typically be elevated due to an increased number of cells producing PSA. Urine cytology is not standard, but it may be considered if there is a predominance of irritative symptoms, hematuria, or risk factors for bladder cancer, such as smoking. The imaging is not recommended unless there is evidence of upper tract deterioration or a need to further evaluate hematuria. And transrectal ultrasound may be helpful in determining accurate size before surgical intervention. In diagnostic procedures, uroflowmetry is a simple non-invasive urodynamic measurement in which a patient voids into a device that measures the volume per time of urine accumulation. This procedure is often combined with measurement of PRV, or post-void residual volume. Uroflowmetry measures voided volume, voiding time, average flow rate, and maximum flow rate, or Qmax. The Qmax is the best measurement obtaining to assess voiding dysfunction. While formal definitions vary, in general with a voided volume of more than 125 to 150 milliliters, a Qmax of more than 50 milliliters per second is often considered normal, whereas a value of less than 7 milliliters per second is suggestive of significant obstruction. Furthermore, it is advisable to use uroflowmetry in conjunction with IPSS. This helps in assessing the severity of obstruction, determining the need for therapeutic intervention to relieve LUTS, and monitoring symptoms relief during treatment. For men with mild symptoms, IPSS less than 7, or more severe symptoms that are not bothersome to the patient, the general measures in treatment include watchful waiting. In addition, simple behavior modification, such as fluid restriction and decreased alcohol or caffeine consumption, may help. The first line of treatment in medication includes alpha blockers. They will reduce muscle tone in prostate and bladder neck. They include taurursine, start with 1 mg daily to maximum 20 mg. Doxazine, 1 mg daily to maximum 8 mg. Tamsulosin, 0.4 to maximum 0.8 mg. Arfusazine, 10 mg daily, or silodazine, 8 mg daily. The side effects of alpha blockers include dizziness, orthostatic hypotension, and ejaculatory dysfunction. Next is 5-alpha-reductase inhibitor. They block intracellular dehydrotestosterone conversion like finasteride, 5 mg daily, or dutasteride, 0.5 mg daily. Also, combination of alpha blockers plus 5-alpha-reductase inhibitors can be used, like tamsulosin 0.4 mg plus dutasteride 0.5 mg. In second line, antimuscarinic agents may help with bladder overactivity. They include oxybutynin 5 mg, tolterodine 2 to 4 mg daily, and solifenacin 5 to 10 mg daily. Next is phosphodiesterase 5 inhibitor, like tadalafil 2.5 to 5 mg daily. The side effects include back pain, dizziness, headache, and dyspepsia. Surgery is often considered a second-line treatment after the failure of medical therapy. However, it may be the first-line option in cases of retention or then dealing with a very large prostate. Open simple prostatectomy is typically used for glands larger than 100 grams. This procedure can be either suprapubic or retropubic. In a suprapubic procedure, the adenoma is inoculated through the bladder. This method is useful for addressing coexisting problems such as large bladder calculi or repairing a diverticulum. In a retropubic procedure, the adenoma is inoculated through an incision in the anterior prostate commissure. Alternative surgical procedures include microwave and water-induced hyperthermia, transurethral needle ablation, laser vaporization, and laser prostatectomy. In addition to therapy, a prostatic ureteral lift may be used. This device mechanically opens the prostatic urethra. It is placed transuretrally under stethoscopic visualization, separating the encroaching prostatic lobes. Complication may occur if the patient is not treated, and include hematuria, bladder calculi, bladder decompensation, incontinence, and upper tract deterioration.